Good evening, dear all. Thank you for the honor of presenting my work at the Virtual Global Spine Conference. Today, I shall present a very interesting topic, spinal intramedullary lesions. So, spinal intramedullary lesions are a formidable challenge for neurosurgeons, spine surgeons, orthopedicians. These cases are unique cases. These cases can change the life of a patient. If complications happen, then it can be devastating for the patients. So these cases are formidable challenge. So I will be fast in my presentation and I shall present case by case. So starting with the case one. So this patient was 25-year-old male patient. He presented to me with just a scan. This patient was not having many deficits. This patient was having minimal deficits. He was able to do his routine activity, but he had this scan which showed a dangerously looking lesion extending from C2 to C5 level and in the middle of the cord. So this my diagnosis was ependymoma in this case. Patient was relatively intact but had a lesion and surgery had to be done. So proper consent was taken from this case and I performed the surgery. So I shall be demonstrating the surgical steps, how I did it. First and foremost important thing is the consent. All these cases are complex cases and everything should be explained to these patients, especially when the patients are in good grade. So you can see how I perform a midline myelotomy in all my cases, and this tumor has been exposed from C2 to C5 level. This is the tumor here, and after excision you can see the cavity, how neatly the cavity is. I am a big fan of these take-up sutures, and I use Vicryl 30 or sometimes Silk 40 to take up the dura. And for the PL sutures, I use the 50 proline. And as soon as the tumor is excised, I close the myelotomy with a proline in a neat, clean fashion by using 60 proline. So the most important thing here is slow debulking of the tumor as well as the use of CUSA. So you can see how beautiful the tumor bed is after the excision. A minimal coagulation is to be done. And I am also sharing the post-operative video of this patient with his consent, obviously. And you can see he did not have any deficit. This patient was really happy after the surgery. So this is case one.
Dipanker, may I ask you, how many levels did you decompress with laminectomy?
I performed a laminectomy from C2 to C5 level. Yes.
So 3 lamina.
Yeah.
Okay.
So presenting my case 2. So this time it was a 35-year-old female patient. She presented to me with some weakness in upper limb. Her power was plus 4/5. She was able to do her routine activities, but again she had neck pain and a scan was done. It demonstrated a dangerously looking lesion. Now this time the lesion is at C2 and C3 level, also reaching up to the C4 level. You can also see on the preoperative scan there is a bit of serings which is starting forming in the lower end of the lesion. So this patient was taken up for surgery after proper consent. I performed a laminectomy. The mode of laminectomy is I'm a big fan of this bone scalpel. I use it for many of my cases. Sometimes I also use the drill with the cutter as well as the burr. So it is not fixed that I use always the bone scalpel or the drill, but all these three things I use by rotation in the cases. So demonstrating the surgical steps, after due consent, I took this patient. I performed a midline myelotomy for this case. You can see how beautifully the tumor has been exposed completely. And I will play a small video clip. You can see how nicely the tumor has been removed from the cord. And this sign which I always see is the flapping sign. See, this means that the patient will have intactness of power and the cord is pulsatile. This is very important. At the end of the procedure, this should be there. If there is these pulsations are not there in the cord, it means some deficits might have occurred to the patient. So you can see, Alex, how neatly how wide this myelotomy was, how wide the exposure was, how wide the flapping of the cord was, and how neatly this has been closed just using 3 sutures. I think I just used 2 sutures. They are the proline 60 sutures. And you can see this patient. This patient video was recorded at 6 months of follow-up visit, and at the MRI which I am showing, you can see the complete excision of this tumor was performed. This patient had one issue, that she had some neuropathic pain, for which I am giving her pregabalins and gabapins, and apart from that, she is doing great. So this is case 2.
Dipanker, I have a question for you. A couple of questions. So how do you identify the electrophysiological midline or even just the anatomical midline to decide when to do your myelotomy?
Yes. So this is a very good question. So what I do is I give a wide exposure, and by this wide exposure, you are already sure that you are in the midline of the cord. So and the second thing is, you always Galgano, you can see there is this vein which is in the midline. That is the most important landmark for me. That is that point I open the cord.
And what is your technique to take these out? You said that you typically will use the CUSA to debulk these. Do you ever just use like a rodent dissector and try to get around it completely and take it out on block without actually, performing, ultrasonic cavitation of it?
Yeah, this is a good question. So what my plan is, I always use the roton dissector, that is a micro dissector, and my assistant who is trained and who helps me all my cases hold this tumor. But I am a big fan of CUSA. I debulk the tumor. I don't take it out in one single piece. That is a big no for me. I in fact never take it out in one big piece, this type of tumor. So I decompress, devascularize slowly these tumors, and my coagulation is always on these tumors, and it will be at the lowest possible cautery setting. So this is my technique to remove this type of tumors. Never in one block, and slowly, and use of CUSA is mandatory.
Now, is that specific just for ependymomas? Like, how would you take out a hemangioblastoma? Would you take that out on block if it was the same size as this?
Exactly. Hemangioblastoma, it has to be taken en bloc. It cannot be taken by, I never take it out by pieces and bits. My plan is always to take out completely in a single block. Yes. Shall I continue?
Yes, please.
So now I will present my case 3. So you will see that as we are progressing in the meeting, my level is increasing. So this time a patient presented to me. He is a 30-year-old male patient. He presented to me with a solid cystic lesion. You can see, Alex, you can see here the lesion is bang on in C2, C3 level, and the syrinx is expanded superiorly, even involving the C1 level. So this is a very critical level. This patient was not in a good shape. He was almost bedridden. He did not have any respiratory depression at presentation, but he was unable to do his routine activities. He was almost bedridden. So this was a high risk case for me, and I will show you how it was done. So in this case also my plan was same. I performed a wide generous laminectomy, and the midline was identified. Myelotomy was done generously. Tack-up sutures were placed, and this tumor was slowly removed, and the whole of the mass was removed, and myelotomy closure could be achieved. And you can see the difference, how wide the cord was opened, and after the procedure, how neatly it has been stitched back using the Prolene 60. And I will just play a small video of this patient after the procedure. You can see he did not have any additional deficits. I perform a freehand fixation for this patient also, and he had a great outcome after the surgery. I was really worried as the level was really high, and even a slightest complication can be devastating for these type of patients. So this is case 3. So
Dipanker, may I just one slide back, please? I have a question for you.
Yes.
On the CAT scan, you can see what is a laminectomy for you, and I see the joints are pretty untouched. In this case, you did a stabilization. What is your threshold? When do you do with your limited laminectomy, facet joint sparing laminectomy? When do you perform a fusion in this case, and not in the first 2?
Yeah, actually, in the first 2 also some things were done. I usually fix the lamina back with mini plate screws, and sometimes I use the screws also. So the thing is, in this, the level was C2 and C3. and actually you in the CT scan it looks like the joints were not open, but in my opinion they were looking unstable intra-op because the exposure was really wide. You can see in the video clip the cord was open so wide, so there was some element of instability. So that's why I went in and fixed it.
Okay.
So now I present case 4. This time it was a 21-year-old male patient. He presented to me with a lesion at C2, C3 level and a large syrinx. This patient was also not in a good shape. He was almost bedridden, and surgery was performed. So this case was unique because this ependymoma biopsy was ependymoma. It was not in the midline, bang in the midline. It was a bit laterally placed. So my plan was the same. I performed a laminectomy for this case. I performed a mylotomy. In this case, this time a little bit lateral, so that I reached the tumor completely, and the whole of the tumor was excised, and mylotomy was closed in a neat, clean fashion. This patient also I performed the fixation. You can see the post-operative MRI on the right side and the clinical video of the patient. Also I am demonstrating. You can see, Alex, I told you that the cord should be pulsatile after the surgery. This is a very important marker for me. If the cord is not pulsatile, then it is a hint for the surgeon that some complications have happened. So if you can see, the pulsatility of the cord for me is important after the procedure. And if it is there, then I am very much sure that the complications are not there and the patient will have a great outcome after the surgery. This patient was almost bedridden, but at 6 months of follow-up, he has regained power in the lower limbs as well as improvement in the upper limbs. The biopsy was ependymoma and the MRI demonstrated a complete excision of this tumor.
So what are you using as far as neuromonitoring for these cases?
Yeah, I use electrophysiological monitoring in majority of the cases, but sometimes if there are some logistic issues, lately I even sometimes don't use the monitoring.
Really? So how are you getting any feedback that you're not injuring the patient throughout the course of the surgery then?
See, in ependymoma, the philosophy is that if you are in the tumor, if you are tumor and you are very gentle on the tumor, the chances of complications are really less. The question for you, the question is, if it is a diffuse type of astrocytoma, that is a difficult case. So case selection is important. You have to have a mandatory monitoring if you are performing a surgery on an astrocytoma which is diffuse, because in that time you don't have the margins, you don't have the syringe, there is no guiding marker. In ependymoma, if you ask me, there are definitely guiding marker. The lesion is compact, or in compact lesions you can even go, you should be using monitoring definitely, but you can do without it also. And this is my personal opinion.
Yeah, there's a question in the chat box from Matthew Barachek asking if you always biopsy the tumor first before you initiate your resection.
No, I never biopsy the case. My plan is always to remove it completely. My plan is never a biopsy. It is completely, see, it is a radiology. Radiology can tell you many things. Radiology can give you clues whether you can take it out or you cannot take it out. So your plans are always fixed before opening the patient.
And the last question I have for that last case is, or I guess for all of them, is how you minimize proprioceptive deficits after surgery, because I do quite a few of these cases too, and it's kind of hit or miss. Sometimes you have a patient that has very minimal proprioceptive deficits, and other cases you have it where they have 5 out of 5 motor strength, but they have to relearn how to walk again because they can't feel where their legs are in space. So what are your tips and tricks to avoid that?
Yeah, so my tips and tips would be like midline mylotomy has to be very sharp. I use knife for opening the midline, and the take-up sutures are the key here. The retraction. See, in all my cases, you are seeing that the cord is being retracted nicely by the PL sutures. So that is my key. So the tracks, you just have to open the cord completely so that you are inside the tumor. All the tracks are literally, and at the end of the procedure, I always close the cord. So I think that helps the patient, the neat and clean closure of the cord, as well as the opening of the cord and the take-up sutures.
So you closed the PIA at the end of the case with what, like a 6-0 proline or something like
Yes,
that?
my favorite is the 6-0 proline. Yes,
Okay.
under high magnification, so that a complete apposition of the pod is there.
And you think that helps deflect some of the proprioceptive deficits after?
Absolutely, I firmly believe in that. Shall I continue?
Yes.
Yes, please.
So my case 5 is now this is another difficult case. You can see that he's a 50-year-old male patient. He presented this time with a cervicomedullary intramedullary lesion. This was biopsy. This was proven to be an ependymoma. The patient was in really bad shape. He was bedridden. He had bulbar signs also. He was unable to swallow, including preoperative. There was rise too. So in this case, I performed a craniotomy as well as laminectomy for this case, and a wide generous exposure was given for this patient. And the steps of the surgery were the same. You can see in the second photograph which I have put, you can see clearly the tumor which is seen in the cervicomedullary lesion. The cerebellum have also been exposed. Bilateral pica is in full view. A midline myelotomy has been done, and the tumor is removed slowly and very slowly. The tumor is removed. It takes a lot of time to remove. It takes patience to remove this type of case. Even a slightest complication in post-operative period can be devastating for the patient. And you can see how wide I have opened the cord, and at the end of the procedure how neatly it has been closed. A big amount of biopsy has been taken, and I would show you the post-operative how this patient improved over 6 months. He had a good amount of physiotherapy after the surgery, and you can see at the post-operative MRI there is no disease, and a complete excision for this patient was performed. He had a great outcome after the surgery, and I was really happy after this case. So case 6. So this is a pediatric patient, 11-year-old male patient. He presented to me with an extra giant intramedullary lesion extending from C6 to D6 level. Alex, you can see that there is a level of syrinx here. Bilateral syrinx is there, but the solid component extends from the C6 to D6 level. So my plan was to excise this solid component as well as open the syrinx on bilaterally, so that the syrinx collapses and the patient has a good outcome. So you can see the wide opening of this cord. In the center, I have opened the cord completely, and the photograph on the first photograph, you can see how bad the tumor is. In fact, the tumor was coming out of the cord, and I just chased it and opened a bit of I performed a bit of myelotomy in the center on the poles, and the whole of the tumor could be removed completely. And the patient also did not have any additional deficit. He was very lucky. This was a big case, and he did not have any additional deficits, which were noticed by the patient, and he was discharged in a good condition. This was a pediatric giant cervicomedullary ependymoma.
So how many levels of laminectomy did you do at that level for this case?
I performed from C5 to D7.
Wow. So did you do any type of laminoplasty or
I always place the lamina back using the titanium mini plate and screws. He was a pediatric patient, so I avoided the screws. I placed it by titanium plates.
May I ask you, when do the patients in your practice are transferred to you? Because these tumors seem to be long-lasting. It's a long history, I guess. Is this the problem in New Delhi? Sometimes patients in Switzerland come with the first slight symptoms, signs and symptoms. What do you think? Should these patients be transferred to you earlier?
Yes, these patients should be transferred to us early on, but I am showing only the unique cases. Small cases I am not showing. So this was a challenging case. That's why I put it. Patient present to us early also, and I will be showing those cases also, in which the patient presented to us quite early. So this case is very unique, Alex. Galgano, this case is very unique to me. You can see that this patient had an extra giant dorsal intramedullary tumor. This patient was not in good shape when she presented to me. She was a 25-year-old female patient, bulky patient, and the tumor was extending like a serpent in the spine. It was a very long segment ependymoma. So I will show you step by step how I did it. It was a D3 to D9 ependymoma. It was like a serpent in the spine. And this case, I will demonstrate exactly how my strategy was. I performed a long segment laminectomy in this case. I used the bone scalpel for removing the lamina, and it gives a very neat and clean cut. The whole laminas can be removed in a quick fashion, in a very fast fashion. The time of surgery decreases drastically by using good equipment, and you can see how nicely the cord has been opened in this photograph. And you can see the tumor is coming out of the cord. It is just coming out of the cord in this center. And in the second photograph, you can see I performed a generous myelotomy, and the whole of the tumor is visible inside. And I have taken the tack-ups on the very papery thin cord, and the tumor is excised completely. You can see how much amount of tumor has been removed. This is just the half amount tumor which is removed. Some part has also gone in CUSA, and you can see here the video I'm demonstrating how big the incision was, how big the laminectomy work was, and at the end of the procedure, you can see the tumor is totally gone, and there are some pulsations in the cord. That is the most important thing. This video was sent by the patient. She was in very bad shape preoperatively, but at the end of 6 to 7 months, she has had some movement in lower limbs and she can walk with support. So that is a big yes for me, because she did not become paraplegic completely after the surgery, and she's a shade better than before. So this case is very unique for me.
So Dipanker, what would you say some of your pearls are for peeling off the tumor from the anterior part of the spinal cord? That's obviously the most dangerous part of these cases, right? So how do you avoid the anterior spinal artery and getting into the corticospinal tracts?
Yes. This case and one case before, this is a very good question. And what my strategy is, I always start from the lateral side. And I always avoid coagulation on the ventral part. Whenever I use the depth, the coagulation is to be avoided. If we coagulate too much and we bother about all the small bleeders, then the complications happen, as the coagulation can go through and through the cord, and the arteries which are on the anterior surface can get injured from the tumor bed. So always I avoid heavy coagulation, and the cautery setting should be at the minimum possible in which we can work. And I use these you can say flow seal also, but I almost never put Surgicel or these hemostatic agents inside. I at the end of the procedure remove them. So my tip here to prevent these complications is this, that don't push too much things in the cord and avoid coagulation when you are in the base of the tumors. Yes. Shall I continue? So this case is unique to me. This time it's a 12-year-old male patient. He presented with a epiconus cavernoma. He had some urinary complaints, but he was able to do his routine activities. He had a little bit of limb weakness, but still he was able to walk without support. So this was a pediatric cavernoma. It was a big size cavernoma. The steps of surgery remain the same. You can see how neatly the cord has been opened. The dark hue and the melanin, dark hue and the hemocytic deposit of the cavernoma is clearly seen as soon as we open. So we are sure that where the cavernoma is, I just give a small myelotomy bang on the cavernoma, and I remove it slowly using the Roton microdissector, and the whole of the cavernoma is removed. You can see how nicely it has been removed and how neatly the closure has been performed of the midline myelotomy. And the patient I am showing, he did not have any additional deficits. He had a good outcome, and the whole of the cavernoma was removed. This was a unique case, 12-year-old male patient presenting with a Conus cavernoma. So Alex, now you see the case now. From giant cases we are going to a small ependymoma. So this Galgano, you can see that the tumor is just mimicking a schwannoma. So it was looking like a very juicy case on the MRI, that it is a schwannoma and a very straightforward case. But the challenge was there in the intraoperative time, because I thought that this is a schwannoma and it would come out quickly, but it turned out to be actually a ependymoma. I would say that it was a exophytic type of ependymoma. It was arising from the conus. You can see in the first picture, this was the tumor which was just arising from the conus. It was arising laterally and pushing all the nerve roots on one side. So I made a cleavage plane in this and shaved off it from the conus. So that surgery, which I thought was IDEM, turned out to be a intramedullary lesion. It was a ependymoma, but thankfully a good cleavage plane could be made and a complete excision could be performed. This patient did not have any additional deficit. This is post-operative video at 1 month of follow-up. She is doing great. So Alex, another
Dipanker, in retrospect, could you have found signs on the imaging that it was intramedullary, or is the MRI not helpful enough?
See, on retrospect, yes, I can have some ideas. The conus was there, and you can see on the second image, the conus was there, and this lump was actually attached with the tip of the tip at the conus. So on retrospect, yes, it should have been kept a possibility. But when you look at the images, you just see the images and say that this looks like a schwannoma. So there can be surprises in TROP. In this case, yes, I was baffled that my assessment was not very correct. I thought it to be a schwannoma, turned out to be epidemic. So this case was performed after this case, I think 6-7 months back. So this case, I was very sure that I am dealing with the ependymoma. This is a conus ependymoma. You can see there is a contrast enhancement, and some edema is also there in the conus region, and the lesion and the contrast enhancement is homogeneous in this case. So she was a 30-year-old female patient. She presented to me with this scan. So you can see, I will show you a short clip. The steps of surgery are the same. I perform a wide exposure. And this on the first photograph, you can see how the lump was attached to the conus. You can see the conus neatly, the nerve roots have been displaced one side, and I have developed a cleavage plane here between the conus and the tumor at very low cautery setting. I have coagulated it and removed the mass. This is the patient after the surgery. She was able to move all the limbs. She did not have any additional deficits. The lesion was compact. A good cleavage plane was there, and she had a good outcome after the surgery. So this tumor was small at the level of conus. So another similar case, Alex, I will show you that this time she was a 20-year-old female patient presented with D11, D12 ependymoma. You can see that this lump is placed just behind the spinal cord. So this radiology was also suggestive of an ependymoma, but this variant was an exophytic type of variant, that the tumor is arising from the dorsal surface of the cord. It is exophytic, expansile in nature, and intraoperatively, the same findings which I noticed on the MRI were there. You can see on the photograph, this is the first photograph of this tumor as open. There is this tumor which is arising exophytically, dorsally from the cord. A cleavage plane was developed at low coagulation settings, and whole of the tumor was removed. And this patient had a good outcome after the surgery. I performed fixation in this case, and she had a great outcome. This lesion is a good lesion to operate because it is an exophytic variant. The adhesions with the cord are not much, and the location is very good. Retraction on the cord is also not much. So this is a good case to operate. So another unique case I would share with you. He is a 21-year-old male patient. So what do you think, Alex? What it can be? Galgano, what it can be?
I would like to pass the question to a neurosurgeon. As the orthopedic surgeon, I'm not so familiar with these. It's obviously an intramedullary, inhomogene.
He's a little bit old for it, but it could potentially be a mixopapillary. Maybe it's at the right level.
Okay, so that is, but in my practice, I have seen so many cases of Conus Dermoid. So this actually turned out to be a dermoid. So I will show you. This was basically a exophytic component as well as intrinsic component. This, as soon as you open the cord, your diagnosis is made that you are dealing with a dermoid. So my preoperative diagnosis was dermoid because I have operated few similar cases, and the radiology is like this, that this is a mimicker for epidymoma, but this was a dermoid. You can see how neatly the cord was opened and how much amount of tumor was removed slowly, the whole, and after the procedure, Galgano, you can see how nicely the cord is and whole of the tumor is removed. A small fixation was performed for this patient. He also did not have any additional deficits. Dermoids are good cases for operation of intramedullary tumors. They have good outcome, but chances of recurrence, in my opinion, are high. If even a small bit of dermoid is left behind, these patients come back with recurrence after many years, and this becomes very difficult to operate when we are operating for second or third time. So another question. So what is your take on this, Alex Galgano? Any opinions?
I will give it a try. Okay.
Yeah, you should try.
So we have contrast surrounding, and inside we have no contrast. Could be intramedullary abscess.
Okay.
It's a session about tumors, I know.
Yeah, I know. No, it is. See, I will rephrase it. It should be actually spinal intramedullary pathology diversity revisited. I will show you diverse cases. Yes. So yeah, you can keep that possibility. Galgano, what do you think it is?
So is that a contrasted film on the right?
No, it is not the contrast film on the right. It is
not, okay.
It
is it contrast enhancing though?
Yeah. Sorry, I'm sorry. It is a contrast enhancing image. I'm sorry.
Okay. I'm just trying to see if it's a non-enhancing lesion. Maybe it's a subependymoma.
Okay, so this turned out to be again an epidermoid. I will show you how this was a small kid, 8-year-old male patient. He presented with paraparesis, and this was actually a cheesy material was there. As soon as you open the cord, your diagnosis is definitely made. This case was unique for me because the location is the dorsal level. At the D4 level, the watershed region. Any complications, any rash surgery, this patient can land up in big trouble, can have paraplegia. The patient thankfully had a good outcome after the surgery. I will show you. He walked with he could walk with support. I was very happy he did not have any devastating complications. The level was really difficult. So this turned out to be epidermoid. So pediatric epidermoid, very rare case at the dorsal level, not at the extremities, but not at the conus, at the dorsal. This was a rare case. So another case, pediatric case. What do you think? What is your opinion? 10-year-old male this time.
It's too hard for me. Would love to hear. May I ask one question to the case before, to the other case?
Yes.
The border between the tumor and the spinal cord, you have presented now 3-4 different types of tumors.
Yes.
Do you see intraoperative a big difference? I'm just a question from an ortho guy.
Actually, intra-op, there is difference in every. See, like epidermoid are good tumors. They are very you just have to use that Hunt forceps, the tumor forceps, to remove them slowly. In epidymoma, the classical thing is the syrinx. In majority of cases, if it is intramedullary long segment, then there would be syrinx on bilateral upper pole as well as the lower pole. So that is a differentiating factor. and the epidermoids don't have these rings. In my experience, I have never seen much big screens in epidermoid cases or dermoid. So that may be a differentiating feature. Preoperative radiology can definitely give us clues, but sometimes there can be surprises intraoperative. So this case is a 10-year-old male patient. He presented with this dangerously looking scan. And Galgano, what do you think it can be?
Maybe it's another epidermoid, right? You've already shown 2 of them.
Yeah. So you are right. This time this scan was looking dangerous, but it turned out to be epidermoid. I will show you this. This was unique because it was a pediatric epidermoid. It is not very common in this age group in my practice. The pediatric patients presenting with this tumor, somebody can think it as an abscess. Some person can report it as a GBM of the spinal cord. It is a dangerous looking tumor, but this patient had an excellent outcome after the surgery. Alex and Galgano, I'm showing a small clip of the patient, how neatly the cord is opened. See, you can see the flapping sign of the cord. It is pulsatile. Whole of the tumor mass has been removed. Whole of the dermoid has been removed. And you can see how neatly the sutures have been placed and the cord has been completely closed. In my experience, this is the most important thing, to close the cord so that there are no proprioceptive deficits. And you can see the cord is neatly closed and it's looking like nothing ever happened. The clip of the patient also I'm showing. This is just, I think, 2 weeks after the surgery, the patient had a great outcome. So this turned out to be a dermoid.
So it looks like you only use what, about 2 or 3 or 4 stitches on the PIA to reapproximate the neural tube?
Yes. In my experience, I don't apply too many sutures. I just approximate them with 2 or 3. And it works fine. You can see in all my cases, even the big myelotomy has been closed by 2 or 3 sutures. Actually, the key here is the meticulous opening. The meticulous sharp opening should be done. Coagulation should not be used so that it can be reposed back. That is the key in my experience.
So how do you open with the myelotomy? Do you just use like an eye blade and arachnoid knife?
Yes, that's a good question. I use the blade. In majority of the cases, I use the sharp blade so that it gives a clean cut. And I use the micro scissors to increase if required intraop.
And then a question about these dermoid epidermoid. Have you ever seen aseptic meningitis after you've taken these out?
I give steroids during surgery, after surgery for 21 days. That is the key to avoid these complications. These complications are very difficult to manage if they happen. So the important thing to note is the meticulous dural closure so that there are no CSF leaks. And to avoid aseptic meningitis, we have to give steroids. I give them for 14 to 21 days without fail. So another case, this time 20-year-old male patient. Alex, Galgano, what it can be?
I don't know. It's an unusual looking lesion. Maybe that's a myxopapillary potentially.
Yeah, my diagnosis was myxopapillary. I was see this location is quite common for myxopapillary, but again this was a dangerously looking tumor. But as soon as we open the cord, our diagnosis is clear, and the contrast enhancement was also there. There was a bit of enhancement, and you can see as soon as the myelotomy is open, the cheesy material comes out, and this again turned out to be a case of Conus Dermoid. So you can see how neatly the cord is opened and whole of the tumor was removed. Alex, you can see how thick the viscous material was. It was just like a pus. But this was a case of Conus Dermoid, which was mimicking. It was looking like a myxopapillary ependymoma, but turned out to be a dermoid. This is good for the patient as this could be removed completely. Shall I continue?
Oh, yes, please.
So another unique case. So my plan is to show some diverse cases. So what do you think it can be? This time 60-year-old female patient. Dorsal location.
Do you have an actual slide, an actual view?
Unfortunately, no, but I will give you a hint. Everything is clear on these two images. You don't need much more images for making a diagnosis. This is T1 and one image is T. First image is T2, second is T1. Yeah, without contrast. No contrast was given.
It's probably
So
a
it's
lipoma,
fat.
right? It's yeah, correct.
Yes, Galgano, that's correct. But you can see the age of the patient, 60-year-old female patient presenting with the lipoma. It is very unusual in my practice. I have not seen many lipomas at this age. She had a she was almost bedridden at presentation. She ignored her symptoms, and before surgery only she was bedridden. So lipoma at 60 years of age is very unusual. So I will show you the slides how this lipoma at this location is difficult to excise. You have to use CUSA in this case, and you have to use bipolar at very low settings. Very slowly you have to remove. This is just a small part which was removed, and a cleavage plane needs to be made between the normal looking cord and this tumor, and you can remove the whole of the tumor. This patient, this patient did not have additional deficits, I can say. This was before and after surgery. But one thing I can tell you that these patients can have deficits, because if we radically remove this type of tumors, then deficits can occur. But if we remove radically but slowly using CUSA and low coagulation, then these tumors can also be removed. So this was unusual case of a lipoma at 60-year-old female. So another unique case I will share with the group today. This is a 4-year-old child presented to me with this scan. What do you think it can be?
Anybody in the audience, you guys could put your answers in the chat box. Looks like someone said blood.
4-year-old child presenting with this type of picture with anxious parents. What it can be? So shall I answer? Shall I show the solution?
Sure, go for it.
Galgano, what do you think? You can take a guess on this one?
I don't know. I'm running out of options here, to be honest with you. Does it have any flow voids anywhere? Like how did the patient present? What was the clinical presentation?
The patient just had back pain, and some bit of urinary incontinence was also there, but not very serious. The main complaint was a bit of limp, which his parents noticed, but he was also intact. If you ask me, when I examined, he could walk. He could not run fast, but he could walk. So this patient presented to me with this scan. So, okay, I will give you the solution. This again turned out to be a lipoma. This was a conus lipoma. This is classical this is T1 picture, which is the first picture that gives you the valuable clues that it can be a lipoma. It was basically on the conus. You can see how brilliant, how nicely it has been exposed, and how dangerously the nerve roots are with this lipoma. But the good thing was the nerve roots were on both sides of this lipoma, and I could make a cleavage plane and could remove almost whole of the mass with minimum coagulation. It could be removed. And this is the child at 1 month of my visit. He did not have any additional deficit. So this was a lipoma in a very small child. It was removed completely. So presenting another unique case. So I don't have many images. This patient was operated many I think few years back, and she did not have any he was bedridden almost, and power in the lower limb was not there. So Alex, what do you think it can be?
So we have just these T2 image. Again,
yeah,
it's a...
but it can give you valuable clues. If you ask me, there are clues in this also. Is this a
huge? Is this like CSF signal inside? Is this a cyst with CSF inside?
Yes, yes, yes. There is CSF. So this case, I will give you the solution. Galgano, I'm sorry for that. I don't have good images for you, but you can try. There are some hints. If you look carefully, there are some hints. This patient did not have the good quality imaging, but was bedridden. I operated her a few years back. So what do you think it can be?
I mean, it looks like some kind of intramedullary cyst here. I'm not completely sure what it is though, what the etiology is.
Yes, you can see there is a dot in the center of the cyst on the back. There's a prominent dot. So I will give you the solution. Okay, the imaging was not good, but it turned out it was a hemangioblastoma. This was a mural nodule which was there at the dorsum of the cyst. The cyst fluid was anthrochromic and a mural nodule was excised. You can see how beautiful the mural nodule was, and under very low coagulation settings, I excised it. And this was a case, very rare case of conus hemangioblastoma with a mural nodule, solid and cystic component. So these are all the 18 cases which I showed you today. So what is the take home message? In my opinion, these cases are rare cases and complex cases. It's always a formidable challenge for spine surgeons to operate this type of cases. With advances in microneurosurgery, safe surgery can be performed in this type of cases. Knowledge of radiology, in my opinion, is the most important thing. Radiology films provide us with a roadmap. We have to have a working diagnosis, what we are dealing with, whether we can remove it completely, whether we have to just take a biopsy, or what results we can give. Everything is clear on the preoperative scans if we look carefully, discuss them. This is not a single person job to operate this type of cases. A good team is required. A good intraoperative assistance is of paramount importance for all these type of cases. And these cases take a toll on the surgeon because they take long time to operate, and it is always a team effort, and good outcome can be given if these patients present us early on and we operate them in good when they have good motor functions. And experience is required. You have to assist in many cases and then perform independently. So thank you so much for giving me an opportunity to present my work on spinal intramedullary tumors. I am really thankful to you all.
Thank you very much that you presented your cases at 3:30 in the night. Now it's like 4:30. Thank you very much. Very impressive. And may I ask you, what is a long surgery for you? Is this like 4 or 6 hours, or is this less than 4 hours?
See, some cases may take up to 10 hours. Some cases may take up to 8 hours. So it depends upon case to case. If it is a very large tumor, then you have to go slow. So time don't matter. What matters is the safety for the patient, in my opinion. Steps should be performed safely. Time don't matter for the case. It should be done in the safest possible way. That is my take.
Okay, thank you very much. We have got some questions from the chat box. First, did you use sometimes a dye like ICG or 5-ALAR? Is this an issue for you?
No, in majority of cases, I don't use the dyes. In hemangioblastoma, it can be this dye can be used. Yes, it was not a talk for today. In dural AVF, yes, it's a very good option. But in that also, if your preoperative planning is accurately very good, then you can do the surgery without the dye also. But that dye is very important for AVM, dural AVFs. In that, yes. For ALA, I know. In ALA, I don't use for any of my spine cases.
Okay. Does anybody from the faculty, from the hosts, use spinal surgery with 5-ALAR or only vascular?
At present, I am not using for spine tumors. No, neither my colleagues.
I have not before. A couple of my colleagues use it for brain tumors.
Yeah.
I have not used it though for spinal tumors. Even for vascular spinal tumors, I just haven't done it.
Yeah. Once we had a nice international exchange of bipolars, good bipolars. There was a question, what setting do you use for the bipolar? Do you have some tips?
Yes, I have some tips. Definitely, I change the settings quite often. When I am at the muscle level, I use it at 30. When I enter the dura, setting is at 50, and on tumor, not more than 10. Not more than 10 on the cord. That is my, and the mode is standard.
Yeah.
I have fixed setting in my mind. Yeah, go ahead.
And one from your experience, and we all noticed that you see a lot of intramedullary tumors. Do you have special symptom signs or markers from the clinical findings where you can predict what is the outcome from the patient after? Do you have some things in mind you can tell us? Be careful when the patient has this.
Yes. So my tip is, see, if the patient is having good motor power and surgery is performed, the patient will have a good outcome if we have done a neat and clean job. But if the patient has low power preoperatively, then good results are not guaranteed. In fact, the patient might not improve or may improve after maybe months. So another thing which I use is this is the most important marker for me. But then it becomes risky sometimes that patient is intact and you have to perform these high risk surgeries. So if preoperative power is good, results will be good if a neat and clean job is done. Yes, that is the biggest marker for me. And if preoperative power is less, then the results may not be encouraging.
Yeah, Dipanker, I completely agree with that. Any patient that comes into these surgeries with a big neurological deficit, you're really not dealing with a full deck of cards neurologically. So it doesn't really take a whole lot to push them over the edge. So I always counsel those patients that they will probably wake up with a worse deficit for a temporary period of time before they hopefully can get back to their neurological baseline. A question I have for you is any tips and pearls that you have for dealing with revisions? I know they don't come along too often. It's fresh on my mind because I had a 10-hour revision hemangioblastoma that had recurred. One of my colleagues had taken it out about 18 years ago and it came back and it was massive. It spanned from C3 to C5. So what are your tips and pearls for taking care of these recurrent tumor cases where kind of normal anatomy is obliterated?
So the most important thing is you should, in hemangioblastoma, you should use the low setting of the cautery. You should always start from the periphery of the tumor. Never you should enter the tumor. All the small feeders on the surface of the tumor should be coagulated, and an aim should be made to remove this hemangioblastoma mural nodule and block. If you enter the tumor and there is bleeding, the hemangioblastoma, if it is totally solid and a long segment, it can be very vascular, and that is my tip, that you should not enter, you should avoid entering the tumor and removing it in piecemeal. You should have the coagulation at the periphery, delineate the tumor completely, and slowly remove it. That is my take on this hemangioblastoma.
Do you use sometimes ultrasound, sonographic intraop to navigate or to resection control your tumors?
Some I never used it. I rely mainly on radiology, the accuracy of marking, and then my plan is you already know where the tumor is. If you see the tumor in the axial sections, you know how much depth you will hit it, whether it is in the midline, whether it is laterally placed. I don't use ultrasound. This is my personal opinion, but my colleagues and other people are using it. It's okay. But
yeah, I agree. I don't think it makes a huge difference, to be honest with you. I mean, I always use it as a secondary marker just to ensure that I'm at the right level. But it's pretty useless in my opinion. I just don't see any benefit from using it. Like you said, once you do your midline myelotomy, you could see the tumor there plain as day in these cases.
Yeah. So I totally agree with you. Same opinion. I don't use ultrasound. It dropped.
So very impressive. I was not thinking about these huge extension of tumors in the spinal cord. It's really impressive. Was it the same for you, Michael, or do you see these extensions in your practice as well?
No, I think Dipanker's definitely shown some longer ones than I've dealt with, to be honest with you. I mean, the majority of the ones that I've seen, and I've done a fair amount, the most I think I've seen one span is about 5 levels. I took out in a cervical ependymoma about a year and a half ago in a young lady, and it spanned about C2 all the way down to almost the top of T1. But like you showed a very impressive one. I think it went all the way down to T9 from T3. So those are some pretty unusual ones.
Yeah. Are you the only center with this amount in New Delhi, or do you have other hospitals who are offering the same service?
Many hospitals offer the same service. We have many hospitals which offer the same services.
So, wow, this was really impressive, and it was really nice having you, Dipanker, and I can recommend to everybody to follow him on Twitter, because these slides we have seen in this presentation, you can find them again online, and it's really nice, and it's really good to have a synopsis. And this was the first time where we have really seen the outcome of every case, which is very nice. Thank you very much that you have shown us these amazing cases. I don't know, does anybody know what is next week on the plan?
I believe, oh, go ahead, Matt.
Yes, next week will be my good friend Michael Kelly doing what he does best, talking about deformity, and it should be outstanding.
So this would be an orthopedic, maybe a little bit more. Thank you very much for this really nice session, Dipanker, and namaste. Thank you very much, and have a good night to everybody, or a good day. It depends on where you live. Thank you very much.
Thank you so much for the opportunity to present my work. Thank you.
Great cases.
Thank you so much.